First and foremost, just want to thank everybody for being here today. My name is Luke Hansen, and I'm with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. It's a mouthful, but it's totally worth it. On behalf of our office and the Alabama Regional Center for Infection Prevention and Control, Training and Technical Assistance, I am very excited to welcome you all to today's webinar, COVID-19 Insights from Alabama, which will feature Dr. Rachael Lee from UAB's Division of Infectious Diseases. We're going to run through just a couple quick introductory points, and then again, give Dr. Lee as much time as possible, and also open things up for hopefully some Q&A here at the end of our time. So just a quick overview about our center. It's relatively new, but the Alabama Regional Center for Infection Prevention and Control, Training and Technical Assistance, or the ARC IPC, was recently established to meet consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. So our center is a collaborative effort between the Alabama Department of Public Health, Infectious Disease and Outbreaks Division, and UAB. And though relatively new, the center is really going to focus on providing training and technical assistance to infection prevention and control, as well as public health professionals in all areas across the state to detect, respond to, control, and otherwise prevent infectious disease outbreaks. Again, we're still in our infancy, but we invite you to learn more about the center in general, to view our past trainings, both now and as we put more in our archive, to request training and technical assistance, and to view any of our existing infection prevention and control resources at our website listed here. That's go.uab.edu/ARCIPC. We also have a very well monitored ARCIPC@uab.edu email account, which you can reach out to at any point. Again, any questions, any recommendations, anything of that sort. And just really quick to plug our next webinar coming up here in a few weeks, we'd like to invite you to Understanding Models to Predict Viral Spread and Community Impact. And that's going to be with Dr. Suzanne Judd. In this webinar, Dr. Judd's going to discuss how models predict viral spread. That's going to include the spread of COVID-19, as well as the impact it has on the community. Dr. Judd's also going to discuss modeling strategies used to model viral spread, how assumptions and models impact decisions that are made from various model outputs, and how models are used in public health policy to control infectious disease spread. So again, that's coming up here in 4 weeks on Wednesday, September 29th at this same time, noon Central. So if you'd like to join, that link is listed here on the slide. You can also reach out to us or visit our website to register for that one. And now it is officially my pleasure to introduce you to Dr. Rachael Lee. Dr. Lee is an assistant professor in the UAB Division of Infectious Diseases. She's also the UAB Healthcare Epidemiologist, as well as the Birmingham VA Medical Center Associate Healthcare Epidemiologist. Dr. Lee completed medical school at the UAB School of Medicine, residency at UAB in internal medicine, and her fellowship at UAB in infectious diseases, quality, and patient safety. She is also an alum of our School of Public Health, where she earned a Master of Science in Public Health. Dr. Lee is an expert in all things related to infectious diseases, from spread of disease to infection prevention and control. So Dr. Lee, it is our pleasure to have you on board today, and I will now turn the proverbial floor over to you.
Today, I want to talk about some insights around COVID-19, particularly focusing on Alabama. Here is our outline for today. We'll talk about the epidemiology of COVID-19 and how that has changed in the face of the Delta variant. I really do want to focus on Alabama and what we are seeing both clinically in the hospital and then as a state, and then talk about vaccination and how vaccination relates to the Delta variant. I think it behooves us, if we're talking about pandemics, to start with talking about the global rates that we're seeing. So the COVID-19 is rising in 72 countries, and this was pulled from routers.com. They have a really great website that really talks about the different number of cases in these countries. By far and away, the United States is leading the charge in terms of the most new infections per day. Additionally, we are seeing an increase in deaths reported in the United States as well. We have over 216 million reported infections and 4.6 million reported deaths. And this is very important because this is probably one of the more deadly pandemics that we've seen. I think recently I saw a study that said it was in the top 5 of the pandemics. 22 countries are still near the peak of their infection right now. So what that means is, you can see these peaks and troughs in terms of cases, but 22 countries are actually in a surge right now, and this is most likely due to the Delta variant. When you look at COVID-19 in the United States, you can see that we have a high degree of community transmission. So 94% essentially of our counties across the United States are in this high transmission rate. And that's an increase in change of about 4.5%. If you think about, I looked at this map probably 2 weeks ago, and it did not look like this. It was much more blue than it was red. So you can see how quickly Delta variant has transmitted across the United States. The 7-day moving average with daily new cases has increased by 2.8%, although that is slowing. So hopefully we are reaching the peak in the United States. But if you look at it within a community, those numbers may change depending on how many people are in the community, what's your vaccination rate, et cetera. We know right now that the Delta variant is driving the rates in the United States. If you look at this map on the right, and so this breaks down these different weeks that you can see the rates. And so the B117 is the alpha variant. That's most likely what caused the surge in and around December and January. And it was the main one that we were seeing. At that point, it was more infectious than the original strain of COVID-19. But as we saw more Delta variant, Delta just completely took over. And we'll talk a little bit about the reasons why. But when I talked to some of the people in the lab, they noticed that, in May and in June, we had a little bit of some of these other variants like Lambda variant, but this Delta variant just completely overtook and is now the dominant variant across the United States and in Alabama. This is potentially dangerous because we know that it's much more infectious, and we also are getting more data that it is more harmful, and we'll talk some about that in a few slides. When you look at COVID-19 in Alabama, we've had 688,000 total cases since the start of this back in March of 2020. But right now, our percent positivity rate is 22.6%, which is incredibly high. This is out of 18 to 20,000 tests per day. So we know we're still seeing a large amount of community transmission. We have heard about outbreaks in different facilities and different school systems. So we are continuing to see this. It's interesting when you look at this graph, you can start to see this kind of downtrend, but I will say, this graph was taken on a Monday, and we always see this kind of downtrend on Saturdays and Sundays because we don't have as many people testing. And additionally, we still have Labor Day to be concerned about. So we have no idea really what's going to happen when we have a holiday in the setting of a very highly transmissible COVID variant. Now, on the flip side, hospitalizations always are lagging behind the total number of cases. And you can see we have not peaked yet. We have about 2,887 hospitalizations around Alabama, and that's increasing. And when you look and when you dive further into this, the Southeast in particular is having just a very hard time. And we actually have a net negative of our ICU beds. So if you take all of the ICU beds in Alabama, and how many beds are being used right now, we actually have a net negative, which is unheard of when you think about being in the set of a surge. So I want to thank Dr. Judd for this model, and you can see she has been working hard on these prediction models for hospitalizations across the state of Alabama, and she actually breaks this down further for Southeast Alabama compared to what we see as a state as a whole. And as you can see, estimated hospitalizations, if we reach a peak of 5,000 and we're already at 3,000, that is very concerning from a hospital system standpoint. We need to make sure that we have enough beds and enough people to take care of these patients. And so it's important because these models really help drive understanding what's going on in our community. Now, just a couple of things to note. If we had a mask mandate, this would reduce this by 30%. And I think this is important for people who are maybe in health departments and working in those places to know that there are things that we can do to bring these numbers down. If you also look at the data, and this is from as a whole in Alabama, we know that COVID transmission is likely being driven by younger ages right now. And unfortunately, I don't have some of the data from the past couple of weeks broken down by age, but there are a lot of groups that are particularly younger as we see schools that are struggling with outbreaks that is driving this transmission. They go home and unfortunately they transmit to their parents or to their grandparents. And then we also are seeing a large group of people in the 25 to 49-year-old range that are having cases. And this is likely because we have lower vaccination rates in those groups. Now, similar to what Dr. Judd presents for hospitalizations as a whole in Alabama, Dr. Russell Griffin has a tight model for our COVID admission projections here at UAB. And what goes into this model includes how many our bed capacity, what our expected number of discharges are. And this is incredibly helpful for administrators at UAB to really tightly control this. And when you look at this line, one of the key interesting things is how flat it is right here. And part of that is due to a large amount of discharges that we're having. We have people that are convalescing these active cases. So what that means is that we determine, hey, you've had this infection now for 10 days, your symptoms are improving, so let's take you off of isolation. And when that happens, we take them out of a COVID positive bed, which then makes more room for people that are actively infected still. And unfortunately, one of the other things that has really controlled or flattened this kind of curve is there has been an increase in death in the past 2 weeks. And I think this is very important to talk about as we go forward, as we learn more about the Delta variant. So let's talk about vaccination. Right now, our global vaccination rates are, we have at least 200 countries that have started their vaccination campaigns against COVID-19. But when you break it down by continent, there's a large discrepancy in terms of who is getting those vaccines. And if you look from here on this left-hand side, you can see that North America, 60% of people have given at least one dose of the vaccine. Whereas in Africa, you can see that you have a large portion of people that have not received a vaccine yet. On the flip side of that, if you break it down by lower middle income and then high income, you can see that we have a larger group of higher income countries that have received at least one dose. That's about 38% compared to the lower income groups. If we think about this in terms of getting out of this pandemic, pandemics are global problems. It's not just the problems that are in the United States or in Alabama. And we have to keep an eye out for trying to get more people vaccinated so that we can get out of this pandemic. Now, within the United States, you can see that we've delivered over 440 million doses of vaccine. In the terms of the total percent of the population that's received at least one dose of vaccine, that's 61.6%. If you look at it, though, I think a key thing here is that if the population over 65 years of age, 92% have received at least one dose and 81% are fully vaccinated. I think it's because we know how bad COVID-19 can be in people who are age over 65. And we worked really hard to trying to get those people vaccinated. And we have actually succeeded in terms of vaccination rates here. But we do have a lot more work to do in the total population in terms of protecting our communities and vaccinating more. Now, you've likely heard in the news about the SARS-CoV-2 variants of concern and how these vaccines work against them. So let's go through this because this is a very busy slide. This came from the COVID-19 Learning Network that's brought to you by the CDC and the IDSA, which is the Infectious Disease Society of America. So the Alpha variant is that B117, which was originally noticed in the UK. And we have multiple different vaccines. So just to orient you here, the mRNA vaccine is going to be your Pfizer vaccine and your Moderna vaccines. Your viral vector vaccines are going to include your AstraZeneca vaccine, which we do not have here in the United States. It also includes our Johnson & Johnson vaccine. And then lastly is the nanoparticle subunit, which is the Novavax, which has not been fully approved yet by the FDA for emergency use authorization. So going across this with our UK variant, which is the Alpha variant, you can see that both the mRNA's vaccines have preserved effectiveness against that variant. And that's what we saw here as well. Likely, we don't know for sure because we weren't sequencing at the time in Alabama, but one of the main things that really dropped the rates across the United States was vaccination. And we know that the vaccines worked here really, really well. Now the beta variant is B117, B.1.351 that was originally diagnosed or originally identified in South Africa. And this one, once again, does have preserved effectiveness with the mRNA vaccines. Now, when we get to Delta variant, which is the B.1.617.2, which was originally identified in India, it looks like there's a little bit of data that is some that say that there's preserved effectiveness and some that say reduced effectiveness. And I think it's very important to tease out what are they looking at in these studies. I can tell you that by far and away that these vaccines are preserve their effectiveness for severe COVID-19 and hospitalizations for COVID-19 and death against COVID-19. But I think we're learning more about this Delta variant in the setting of these vaccines about whether or not it prevents mild disease. So among fully vaccinated people, vaccination is more than 90% effective in hospitalizations. And there's actually a study recently that came out of New York State that looked at the overall effectiveness of COVID-19 vaccinations. And while there was a decline from about 92%, which is what we originally saw with the vaccines, to about 80%, there are a few things that are compounded with this, right? This was likely due to the variant Delta, but then it's also due to some relaxation of masking and physical distancing. So when you have those things coupled on one another, you can really see some breakthrough infections. But the key here, though, is that they are 90%, more than 90% effective against hospitalizations. One of the things that I think about in terms of these breakthrough cases is really about denominator data, right? So when I tell you that we have 10% of our patients that are admitted in the hospital that are fully vaccinated and have COVID-19, I'm telling you of the total number of people that have COVID-19, how many are fully vaccinated. But you really need to think about it more in terms of how many people who have been vaccinated have COVID-19, have been exposed and have COVID-19. And that number is much lower. And ADPH recently put out data that said 1% of the people who have had breakthrough cases out of their total number of people vaccinated. So denominators matter. And I know that in the School of Public Health, there are some very vocal people that believe the same as I do. So really to drive this home, the Joint Commission has recently released this data, and I think it's helpful visually to understand what do we tell people, our loved ones and the media, what do they hear about whether or not vaccinations work. So we know approximately 170 million Americans are vaccinated, which leaves around 165 million Americans who are unvaccinated. So that's almost a 50-50 split. And so if we said that vaccines had no effect against the Delta variant, the death toll would look really similar and almost identical between vaccinated and unvaccinated, right? So we would have we know that 5,564 people died from COVID during the week of August 15th through 21st. And so if vaccinations made no difference, we would see this, right? We would see the same number of people who are vaccinated to unvaccinated dying from COVID-19. But what we actually see is this. These are the 6 to 278 fully vaccinated people who have died. And you've probably heard about these cases more in the breakthrough news, on the news about breakthrough cases than any of these other cases. And so this is once again why denominators matter. And we really want to remind people to get vaccinated and to also do our part to physically distance and to wear a mask to get us out of this. Now, if you think about vaccination rates and can they truly control COVID-19, I think this speaks mountains in terms of whether or not vaccination can get us out of the pandemic. And if you look at the percent of states that are fully vaccinated, and this data, of course, is already old, which is, I hate to say, this is less than a month old, and the data is already old. But you can look at here, the percent of states that are fully vaccinated and their rates. And so Vermont, of course, is leading the charge in terms of having fully vaccinated people. And then this is your 7-day rate of cases per 100,000. So of these states, these are the ones that have much lower percent vaccination rates, and they are the ones that are seeing a COVID-19 surge. Another way to look at this is by area, so Northeast, South, West, and Midwest. And this data came from the New York Times. And much of the South, which is that light blue line right here, is really contending with some of their most serious outbreaks of the pandemic. And I can tell you, at least being in the hospital right now, that this surge that we're seeing is as bad, if not worse, compared to what we saw in December and January. So what about Alabama? Well, let's look at our percent fully vaccination rate. So I think this data is probably some of the most exciting data that I will present to you. And it's really because of this blue line right here. So when you look at the dates here, so this was in June, and I think we had a large portion of people that were getting vaccinated, and that trailed off very quickly. And with the concern and rise of Delta variant, with people continuing to talk to one another about vaccine hesitancy and about some of the reasons why they're concerned about the vaccine, and really working with people to understand why it's important to do that, we've seen an increase in the total number of vaccinations. And so Alabama is no longer last in the nation in terms of COVID-19 vaccination. And in fact, Jefferson County has 47% of their population fully vaccinated. 65% of the vaccines in Alabama today are first doses. So kudos to anybody that has been able to talk to their families, friends, loved ones, colleagues about getting vaccinated, because it works. It takes time, but it does work. Now, this data comes from the ADPH dashboard, and I think it's helpful to understand who is receiving these vaccines. So on the left is the total number of people of our COVID-19 vaccines, what percent are getting what in that age group. And so for the most part, very low number of children are getting vaccinated. And then if you look at this light blue, then about 12% of the total number of people that have gotten vaccinated are 75 and up. But if you look at it on the flip side, so let's take our demographics of Alabama and what percent of those have initiated COVID-19 vaccines. So here, 75 and up, 78% of the people who are 75 and up have initiated COVID-19 vaccines, whereas those who are younger are much less likely to have initiated their vaccines. And so this is where we really need to work on improving concerns about vaccine hesitancy. Similarly, you can look at race of people who are receiving COVID-19, and about 56% of the total number of COVID vaccines that have been given in Alabama are who are white. And that accounts for about 36.2% of people who are, say that they are white on their demographics. So in this case, even though this is a lot of people, we do need to do some more work in these different areas to understand why people are still hesitant about receiving the vaccine. I'm hoping that the FDA full approval will continue to move the needle for some people that were maybe on the fence and thinking that it was an experimental vaccine, because now we have full approval, at least behind the Pfizer vaccine, and likely we'll get that against the Moderna. So let's talk about clinical considerations with the Delta variant. So the Delta variant is much more contagious, more than 2 times contagious. And if we think about R0, which is the number of people that one sick person will infect on average. So with Ebola, that was about 2 people, right? And when you think about how Ebola is transmitted, it's really through touch. And so the R0 is 2. When we think about the original strain of COVID-19, that was about 3. But the Delta strain appears to be around 6 to 7, which is pushing it closer to chickenpox. So for every 1 person that is sick from COVID-19, they will likely infect 7 people. Now, this is different compared to some of our airborne viruses like measles, which is 1 to 18. So measles is by far and away our most infectious virus that we have out there. Now, to go back to understand about airborne versus droplet, et cetera, I think it's important that we talk about what these words mean. So aerosols is an overarching term, it includes the range of particles. Now I found that articles don't really clearly spell out what type of aerosols that they're talking about. And in fact, this science article just came out last week, and they use the word aerosols when they're trying to mean droplet nuclei. Droplets are these droplets that are larger than 5 to 10 microns, so that's about 1/10 the width of a human hair, and they fall to the ground because they're much heavier. And these typically fall to the ground anywhere between 3 to 6 feet. Now, droplet nuclei are those that remain suspended in the air, and they can evaporate quickly, but they can leave behind viral particles, and they can remain airborne. And that's what we're talking about here in these little dots here. And so we know that by far and away, the most likely way that COVID-19 is transmitted is through this droplet nuclei. So you're close, you're not wearing a mask, and then you get exposed, and that's what we see. Now, there is concern for airborne transmission. I will say that these airborne transmission occur more likely in the hospital when we are doing things to them to aerosolize and make that virus airborne. Now, when we think about this in terms of the Delta variant and transmission, transmissibility really depends on a variety of factors. It includes your duration of viral shedding, it includes ventilation, it includes the symptoms of patients, includes whether or not you're wearing a mask when you're around one another. I think the key thing here is that when we look at Delta variant in terms of if you're fully vaccinated versus not, you have the same amount of viral load in your system. And so the concern is that people who are fully vaccinated that unfortunately have the Delta variant and a breakthrough infection may be able to transmit it to others. There was a large outbreak in Barnstable County in Massachusetts, which is where this study came from right here. And there were 469 cases of COVID-19, and 74% actually occurred in fully vaccinated individuals. And this was all driven by Delta variant. And you can see this thing called the CT value, which is the cycle threshold. So that's how many times the PCR machine has to turn over in order to detect the virus. Lower means higher amounts of virus. And so you can see here, they had very similar rates of virus. But an interesting study that came out of Singapore tried to really tease this out more between the unvaccinated and those who have vaccine breakthrough cases and are fully vaccinated. And you can see here that in general, up to day 6, we have the same amount of viral load, but then our vaccine antibodies kick in and controls that very quickly, bringing that down to hardly any virus in a very short period of time. So if we think about using vaccination to control pandemics, this is the key here, right? Because we still have antibodies that recognize the virus when they kick in. And this likely is why a lot of people may have mild symptoms with their breakthrough infection, and then they go away very quickly. Now, when we think about secondary attack rates, so that's that R naught that we're talking about among household and non-household contacts, it does appear that in unvaccinated individuals, Delta variant infections are at least twice as infectious, and we see a higher rate of these secondary attack rates. So anything from a range of 10 to 20%. So putting this all together, when we think about airborne versus droplet, I think one of the things that I have learned as an infectious disease doctor is that this droplet and airborne transmission are really not a dichotomy, and instead it's a continuum that many factors can affect. So on one side, you may have droplet, on the other side, you may have airborne, and then there's a whole bunch of small particle aerosol transmission, or SPAT, if you want to call it that. And so this spread is when you have poorly ventilated spaces in very large amounts. So when we think about this in terms of true airborne pathogens, the measles R naught, like we said, is anywhere from 12 to 18. The household attack rate in unvaccinated individuals is 90%. For tuberculosis, which is an airborne pathogen, the R naught is 10, and these attack rates are 50% in households. With COVID-19, with the original strain, it was 2.3, or anywhere between 2 and 3. And then the household attack rates were 10.5%. But with Delta, we're seeing increase in these attack rates from anywhere from 10 to 20%. So what do we know right now about severity of disease? And this study actually also came out from the Lancet. It came out recently that looked at 43,000 COVID-19 positive patients. And they looked at those who had the alpha strain, which was about 34,000 or so, compared to the Delta variant. So much lower numbers because this is at the beginning of the surge. By far away, Delta patients were younger with a median age of 29, and Delta had twice the risk of hospitalization, particularly in the unvaccinated. So when you look at this adjusted odds ratio or adjusted hazard ratio here, it was 2.26, which is quite high if you think about it. So even though they were younger, we're seeing more people that are hospitalized. Additionally, Delta used the emergency department more frequently than Alpha patients. So if you think about the strain on healthcare systems and how we can see that ERs can become very overrun very quickly because of this issue. What about reinfection? Well, unfortunately, it does sound like potentially we can get reinfected with Delta. And this is a study that came out of MMWR that looked at among Kentucky residents who were previously infected with SARS-CoV-2 in 2020. And then they compared those who were unvaccinated against COVID-19, and they had a higher likelihood of having reinfection. Now, there is a preprint article that just came out of Israel, and you may have heard about it, that said that natural immunity has this longer lasting and stronger protection compared to the vaccine. I think it's very important to first point out that this is a preprint article. It has not been peer reviewed. And it's difficult to understand the data is truly capturing efficacy of the vaccine versus natural immunity. And then we have no way to predict who will develop enough antibodies to be considered protected after COVID infection. It's almost like Russian roulette. If we can give you a vaccine that we know is safe and effective, rather than you go get infected with COVID-19 and potentially have symptoms of long COVID, then I think I would choose vaccine over getting infected. So as we work through some of this data and how it relates to UAB, I think it's important to note that we have really been trying to tease out patients who are fully vaccinated who are admitted with COVID-19. And so with the help of Dr. Griffin, over a 30-day period from July 15th to about August 15th, we have had 531 admissions to UAB for COVID-19. 12% of those are fully vaccinated. And about a third of them are actually immunocompromised. If you look at the definition of what's considered immunocompromised based on the CDC, over a third of those met that definition. And when you look at those who are fully vaccinated, by far and away, their median age is much older. So 66 is the median compared to 50. And they have more comorbidities. So in this group here that are not vaccinated, the vast majority of them have no or one comorbidity and are overall younger in age. So this really drives home the issue that we are seeing here with our the cases and the burden of hospitalizations at UAB. So in comparison for Delta versus other variants, in unvaccinated people without prior infection, Delta achieves a higher viral load than other variants, and Delta is at least twice as infectious. In vaccinated people with breakthrough infections, Delta achieves that higher viral load compared to other variants, but we still are wondering how much more infectious Delta is in this population, and we still have questions to answer here. So I want to talk about something that is near and dear to my heart, which is preventing the spread of COVID-19 in schools. I have two children that unfortunately cannot get vaccinated yet. And because of that, I think a lot about their risk when they go back to in-person school. I think this is a great study that looked at in-person teaching in Los Angeles. And so this is Obviously, this is before Delta. So this is right around December and January when they had the beginning of their surge. And they looked at this period of time from September 1st, 2020 to March 31st, 2021. And they had a total of 463 school-associated cases among those attending public schools. And then they had 3,927 among staff members working on site. But in schools that had safety protocols in place for prevention and containment, which includes things like masking, symptom screening, physical distancing, and contact tracing, the rates in children and adolescents were 3.4 times lower during the winter peak compared to rates in the community. Now, what breaks my heart right now is this Alabama dashboard. This was recently updated last week for number of cases of kids K through 12 in terms of rates of infection. And they had 4,337 cases. And most people started school about 2 to 3 weeks ago. And this is just, you know, red is bad. And if you see all this red, this is a bad sign. I'm sure you've seen things like this in the news. So Lee County schools where masks were optional, you can see the number of cases that they had. That really causes closures, it causes quarantines. And then when you look at Auburn City schools where masks were required, in that same period of time, they had very minimal number of cases. I think that points easily to the reasons why we are recommending masking, even though we also have a vaccine in place. And if that doesn't really prove to you the reason that we are requiring masking or recommending masking in indoor settings, here's Delta variant. Here's an unmasked adult. And I think the story was that she was take her mask down to talk to the class. And she worked for 2 days with symptoms. And lo and behold, here are all the people that were positive after she came to work twice and while still having symptoms. And so this shows you how infectious Delta is and the importance of wearing a mask to prevent that spread. Now, one of parts of my jobs as a healthcare epidemiologist, I think a lot about ventilation for controlling the transmission of COVID-19. We know ventilation works, masking, cleaning high-touch surfaces, staying home when you're ill, distancing, and of course, vaccination. I will say ventilation is probably one of the harder things for people to understand, mainly because if you haven't taken physics, it takes a long time to think about airflow direction and what it means when you have an HVAC system with filtration. But I think a lot about this, and we talk a lot about this in the hospital in terms of what's the direction of airflow in terms of positive pressure and negative pressure. How can we improve ventilation and filtration through specialized filters? And all of these things we know work. And so natural ventilation, of course, works as well. That means just opening up the windows if you are in an area that doesn't have as good ventilation. So, you know, it's always surprising 20 months into a pandemic where we start questioning whether or not the things that we know work actually work. And so I think it's important that we have the data about mask wearing. And some of the data that we have actually comes from a Cochrane review from Respiratory Viruses pre-pandemic. And so in this Cochrane review of 67 studies that included randomized controlled trials of respiratory viruses, they found that surgical masks and N95 or N95 respirators were most consistent and comprehensive supportive measures. And so if you don't know how to read a Cochrane review, this little dot is the thing that you look at. And you can see here that these favor masks. I love the commentary that they had in here because they said N95 respirators were non-inferior to simple surgical masks, but were more expensive, uncomfortable, and irritating to the skin. I think this is important for community transmission and understanding why we are recommending masks for people in the community. I will say there are no randomized controlled trials of masking in the setting of COVID-19. With the exception that I think I saw a paper today that is in Bangladesh that was looking at a cluster randomized controlled trial. But they are somewhat unethical when we're trying to prevent the spread. And so we really need to think about what are the results of our observational studies, and what does a randomized controlled trial add to what we already know? So here's some effectiveness studies, and these are epidemiologic studies of mask wearing to control the spread of SARS-CoV-2. And you can see here, you've heard about this, you probably heard about this a while ago, about this hair salon in Missouri, where they had 139 patrons, and there were 2 infected with symptomatic stylists. Nobody developed COVID-19 because there was universal mask wearing. Same thing here. As you go down, you can see 70% reduction risk, 79% risk of secondary infection, 77% of reducing. So this overall has great data and large numbers to support the use of SARS-CoV-2, of masking with SARS-CoV-2. And if that doesn't help you, I was lucky to be a part of this study here that we looked at decreasing high-risk exposures for universal healthcare workers. And so being in the command center during this time where we were making decisions to care for patients when we didn't have much data was very difficult. But what I can tell you is that the moment that we decided to say universal masking for anybody coming into the hospital and for all of our healthcare workers, we had a reduction in the rate of high-risk exposures per patient day by 68%. When we added universal testing to this, that further decreased exposures by 77%. So this data in and of itself, along with everything else that we know, really points to the reasons why we are recommending masks, especially in the setting of a more infectious Delta variant. So I wanted to leave time for questions. I really want to thank the ARC IPC for letting me talk. And I was lucky enough to go on vacation with these boys here to Colorado right before the surge got really bad here. So I hope that you are getting some time off, taking breaks, but being safe, especially as we are about to go into Labor Day.
Dr. Lee, thank you so much. And thanks for leaving time for questions. So we have had a couple come in the chat, and I will say again, anybody, if you have any questions, please go ahead and put those in the chat box and we'll get those asked. But I will start with the first one that came in. And so just this was a question about clarification. And so it's strictly asked, even breakthrough cases are not as severe, recovery rate is faster, and we, parentheses, the fully vaccinated, do not spread COVID at the same rate.
Yeah, so I think that, we are still learning a lot about breakthrough infections, but I completely agree with those statements. We know that people tend to have milder symptoms. People also don't have as much virus, or they have the same amount of virus, but they're able to control it faster. And then hopefully they are able to resolve their symptoms quickly and get back to health.
And then a second question that came up was just another clarification, explanation. Would you mind explaining again what a Charlson score is?
Sure. So a Charlson score is a numerical score that you get. You can actually Google Charlson comorbidity score, and it gives you an understanding of how many comorbidities a single person has in comparison to the general public. So, that includes things like diabetes and liver disease, if you have cancer, and those sorts of things. The higher the score, the worse that you are. So what we would think about at the beginning of the pandemic, that Charlson comorbidity score would be much higher because age is also included in that. And so it helps kind of take that data and understand, let's take this Charlson score and look at it in comparison to people that are not as sick and as ill.
I had one come in as you were talking there. Just a general inquiry, if you had any information or insight on the South Africa variant at this point.
So the South African variant, I think we saw a fair number of those cases actually when the Johnson & Johnson vaccine was under its trial. I think those numbers have calmed down. I know there are a few other variants that we're still learning about. The biggest one is Lambda, which we don't have much data on. And then the other one that we are learning about is the C1, which I think has a lot of news in the media right now. But really, we don't have much in terms of its characterization. I think there are very few cases of C1 to be concerned about right now. And really, we need to focus on getting out of the surge rather than focusing too much on the variants. And the way I think about as a reminder, the only way you get variants is when the virus transmits to another person and starts to replicate. It does it in a messy process, and that's how you develop a variant. And so if we can prevent that process, and that means including masking, distancing, vaccination, all of this layers of protection, then that will stop variants from occurring.
As you were talking there, I had a few more questions come in. Specific to the Pfizer vaccine, Alabama, has full approval had any impact on vaccinations to this point? I know it might be early to make a statement there, but any insight on your end there?
So I looked at the data yesterday when I was making those final slides, and it was approved about a week ago, and it looks like there's a huge increase, at least on one day. I think we'll have to wait and see if that increase continues. In talking to my patients, I've definitely had a few that have said, I'm waiting for full FDA approval. I've tried to break people of that some, because we probably have more data about these vaccines than any other vaccine that's been fully approved by the FDA. So I think that's the key, that you tell your friends and family that the data is already out there. The data is very strong, and it just takes time for the FDA to go through that approval piece.
Switching over to masks and face coverings in general, I'm going to go first with a question about masks specifically and then face shields. But just for clarification, are surgical masks as good as K95s? And then just any insight, information, evidence about cloth masks and their effectiveness?
When I think about masks, I think about a couple of things. I think about the filtration, and then I also think about the fit. So you could probably have the best mask in the world, but if you put it on your kid who wears it like this, which is a problem that I have with my kid, mainly because I feel like no mask fits its face, then you're not going to get the benefit of any mask. I feel like some of the best masks that I have is actually a cloth mask that is able to fit fully around my face, and I'm able to go into the community. And so those are the things that you should think about in terms of fit and efficacy. Now, if you take away all that stuff, so let's just say that the mask fits perfectly on the user, what about efficacy and filtration? N95 by far and away is the best, because we use those for airborne pathogens. The KN95s, based on what we know, they are really good. The problem is that every company is different, and so there are some that are not FDA approved. And they likely get better filtration than, say, your standard surgical mask. Even within surgical masks in the healthcare setting, we have some that are much higher rated compared to lower rated. And that really has a lot to do with fluid resistance. So we use certain masks in the OR. So putting all of that together, what do I do in the community? I wear a cloth mask that fits my face incredibly well. And what do I do in the hospital? I do a surgical mask, because that is required by OSHA and by CMS. And then of course I do an N95 for patients that are that I'm seeing that are COVID-19 positive.
Okay, perfect. And then switching over to face shields, this is from a parent of a younger child. Says, my daycare uses face shields so the children can see their face. Are these effective in preventing transmission of COVID?
No, I think I was such a huge face shield proponent at the beginning of COVID, but we've learned more about what truly protects our face and protects us against COVID-19. And the addition of a face shield in addition to your mask is shown to really reduce risk. There was a study that was done, I think it was in India, where they did contact tracing for patients who were COVID positive, and they had a regular face shield and a regular surgical mask, and they had no positive transmission from those COVID positive patients. So I think that's really great data. I think the thing with face shields, and what I've heard from school administrators is it has been difficult to teach younger kids, how to pronounce their words and and they may need to see that. But that's not good enough if you're wanting to prevent transmission. And so really want to remind people to have their kids wear masks if they're old enough to wear masks, and outside of maybe teaching those phonics lessons to really put that regular mask back on.
Okay, very cool. Well, we have a couple more questions, and then we'll kind of tie things up here. But sticking with that younger group, Kind of asking you to put your Nostradamus hat on here. Do you think vaccinations will be approved for those 12 and younger? And if so, any idea what a timeline might look like there?
I am hopeful that by fall, we will have some FDA EUA for the vaccines that would be between the ages of 5 to 11. I know that they are collecting the data right now. I think they are they had to reduce the dose because they're younger, of course. And so they're not having to reinvent the wheel, but they are having to make sure that the vaccine is still efficacious. And so that may be some of the delay. I had heard initially as September, but I think it's going to be October or November would be my guess as Nostradamus.
Well, cool. I'm going to have you do one more prediction for us then, and hopefully get us out of here on a good note. But we had someone ask, based on prediction model indicating an estimated hospitalization decrease by early November, do you think that transmission rates will then be lower in the community? And if so, if the holidays might be a little bit more normal? And again, knowing there's myriad factors there that go in. I know you mentioned Labor Day just being one of those as something coming up, but going into the holidays in general, anything that you can interpret or pass on to us?
Yeah, what we do know about coronaviruses is that they typically they are seasonality to them, with the winter time being one of them. But I think if we can continue to wear masks, get more people vaccinated, I'm really hopeful for a more normal holiday. I would love a more normal holiday. Let me just say that.
I think we all would. And we had one question coming under the wire that ties in there. But again, based on speculation and expertise, if vaccines go up, admission rates go down, do you think we could be back to not wearing masks in public within, do you have any idea what a time frame on that might look like?
I think we may have potentially jumped the gun a little bit with that fully vaccinated being able to wear masks. I think it came out of a place where we had the best data available, right? Based on what we knew before Delta, like these vaccines work incredibly well. And even if you're exposed, you should be fine. I feel like we need to not go so quickly in removing masks because for me, they're easy enough to wear. And instead, focus on how can we get back together and remove physical distancing, which I hate. Like that physical distancing is probably the hardest thing. But still continue to wear masks. Masks to me would probably be the last thing to remove as we're getting out of this pandemic.
And I keep saying last one, but they keep coming in last minute. So just with our last couple minutes, you touched on variants earlier, but again, one more look to the future. Any indication of other variants coming based on how they form, anything in the research right now, anything like that?
I know the one that we were hearing about is Lambda, the Lambda variant, which is next in the Greek alphabet. I don't know if we have much in terms of the characterization, but I think if we can get out of this Delta variant, I mean, the good news is that we haven't heard of other areas having an increasing surge with another variant. So hopefully as we get out of this and more people are vaccinated, then we'll have more ability to control this.
I'm going to say that's a hopeful note. Dr. Lee, one, thank you so much. But any parting words for us as we get ready to call it a day? And I'm going to share screen while you're giving those final thoughts.
I think we are all exhausted, right? 20 months into this, it's incredibly hard to continue to fight the good fight against this pandemic. So don't lose hope and, continue to work on people that may be hesitant with vaccinations because we've been able to successfully see people get vaccinated. So hang in there.
Well, Dr. Lee, again, thank you so much. Everybody listening today, thank you all so much for your time, for joining us today, for the questions that you gave. We'll shamelessly plug again on September 29th, Dr. Judd's presentation on understanding models to predict viral spread and community impact. And once again, be on the lookout for that email from the ARC IPC email account. Your feedback is invaluable. We hope to get your evaluations back, and we hope to see you all back here in a few short weeks. So thank you all again for joining us, and I hope you all have a fantastic day.